Thank you all very much for inviting me to speak here. Bishop James and Iman have spoken to the increasing mainstreaming of HIV within communities. We see now HIV no longer just affecting key populations, but being something that all communities deal with right at the hearts of their communities. But I also want to speak to you about one of the key drivers of the HIV epidemic, particularly in Eastern Europe and in Southeast Asia, and sadly also now in East Africa as well, which is the impact of HIV among my community, among people who use drugs. My name is Matt Southwell. I am project manager for an organisation called the International Network of People Who Use Drugs. Over the last 18 months, I've been responsible with my board for building an organisation that is both able to speak for people who use drugs on the global stage, and also to build capacity among our community at a country level to help people be meaningfully involved in local projects responding to HIV. I have used drugs for 27 years of my 45 years. I have had moments of deep love and connection, intense belonging, community, overwhelming joy and spiritual insight while using drugs. Conversely, I have also had times when I was locked in dependent drug use, became disconnected from my body, distorted in my thinking, and my family relationships were strained. So of all people, I understand the complexity, the challenges and the contradictions of drug use. I'm not here to advocate for a permissive, decadent, nihilistic, individualistic and immoral world. Instead, I'm here to speak for a community that is often misunderstood, too frequently scapegoated, and routinely pushed onto the margins of society. Over the last 18 months, I've spoken in front of large UN meetings full of politicians and policymakers, some of whom were clearly neither welcoming of my presence nor contribution. I well remember the sight of one country delegate, who will remain nameless, at the Commission on Narcotic Drugs, who physically jumped back 2 steps when advised who I was. I am not normally reserved about public speaking. Perhaps that's one of the legacies of being the son of a Church of England priest. However, I have to admit to a great deal of nervousness and anxious anticipation about speaking to you. I think this speaks to the experience of my community, of the expectation of my community, that we will be judged within society, and particularly within our engagement with religious communities. This is very significant because we know that self-belief in and of itself is the biggest determinant of effective outcomes in treatment. So when we are not believed in and don't believe in ourselves, so we start to reduce the potential treatment outcomes that we face when trying to seek help around our drug taking. Furthermore, when we did a survey in the UK, one of the most benign drug treatment systems, we found that 80% of people who had an acknowledged drugs problem chose not to enter drug services through fear of judgment. Last February, I was in Kiev working with drug users from 9 different countries in Central Asia and Eastern Europe. During that time, we were able to benefit from the new opiate substitution therapy programs, the methadone and buprenorphine programs that had been opened up in Ukraine. We had activists there from Russia who had their first experience of coming to a meeting and taking buprenorphine, allowing them not to have to rush out seeking heroin, no longer having to be heavily intoxicated during meetings, and everybody noticed how powerful and effective our engagement was together. In fact, these groups went on to form the Eurasian network of people who use drugs at that meeting, which is now working in partnership with a number of UN partners. However, the hardest thing about that meeting was working with one of my brothers, Alexei, from Russia, who lives with HIV, has 2 children, and is a human rights activist. He had the experience for 3 brief days of being on buprenorphine, and then had to return home to a country where that was not possible, where he was sent back without any treatment. And that, for me, was one of the hardest moments of my life, to see a friend who had just seen the benefits of life-saving treatment and was then sent away from them. I want to talk to you about 2 aspects from a very personal level about my experience of working with faith communities. In the face of illness and death, we are always confronted with our mortality, and also it generates our awareness of our own spirituality. In the late 1980s and 1990s, I was part of a team, a health service team, but a team that openly employed people who use drugs within our staff team. So half the staff team were drug users, and the other half were from more traditional healthcare backgrounds. We responded to the advent of HIV within our community, within our local community of the East End, a very diverse community, 40% of the population from black and minority ethnic communities, but we also had a substantial population of Italian drug users, people who had fled the very harsh drug policies in Italy and moved to London, bringing with them the very high levels of HIV within their injecting drug using populations. So 50% of my caseload as an official drugs worker in those days were from Italian communities. 25% were from Scottish communities, and the other 25% were a mixture of communities from our own local area. One of the challenges we faced was having people who use drugs being rejected from hospices, from hospitals, from terminal care settings because they were drug users. And people felt uncomfortable about holding them in a setting where they were seen to undermine the ward and to not comply with treatment models. However, to expect people to make fundamental changes in their drug use at the moment when they were dying seemed somewhat unrealistic. And we were seeking to provide our friends with dignity and stability as they saw out the end of their lives. So we formed a terminal care team made up of our own community, people who understood what it was like to live with drug use and to live with stigma and discrimination. We, over a period of 10 years, cared for 60 of our friends who died of HIV. And it had a very substantial impact beyond seeing our own friends die with dignity and respect, for which for me was one of the greatest privileges of my life to see that, to be able to give that gift to my community and friends. What I hadn't anticipated was the impact that it had on those people's families. We had a fantastic Italian Catholic priest who was in London to service the Italian community living in London. And Father Carmelo was a bit of an unorthodox Catholic priest, and he took on as his mission not just to look after the traditional Italian community in London, but also to look after this community of drug users from the Italian community as well. And he routinely took his work into the prisons and into the homes of people living in London. And in fact, he travelled as far as Bangkok to go and see his parishioners, as he accurately described them. One of the challenges for us of holding our community was often working with people who were very unwell and often away from more traditional hospice support because we were not welcome in those settings. But we were very fortunate to work alongside nurses who helped us and supported us to provide community care to our fellows. And one of the greatest compliments that Father Carmelo ever gave us as a group was to say the difference between us and the more traditional services was that we worked with our hearts. And I think that maybe speaks to some of the challenges that we are seen as sort of nihilistic, anti-community, anti-love, anti-human, or anti-humanity when we take drugs. When in fact, what I've seen among our community caring for each other is some of the deepest acts of love, the deepest acts of compassion, and the deepest acts of understanding in caring for people who sometimes were very troubled and challenging to look after.